Ladies and gentlemen, dear chairs, let me present you my PhD topic about prognostic factors of serum biomarkers in urothelial cancers. I'm Ádám Széles. I'm a resident doctor here in Semmelweis University at Department of Urology, and my vision is therapy optimization of urothelial cancers, and as a mission I would like to assess the utilization of different biomarkers in the aspect of urothelial cancers and immune checkpoint inhibitors. And according to this mission, these are my three ongoing or even finished projects where I assessed different biomarkers in the aspect of urothelial cancers and immune checkpoint inhibitors. So please let me go one by one. My first article titled Pretreatment Soluble PD-L1 as a Predictor of Overall Survival for Immune Checkpoint Inhibitor Therapy. This is a published article to Cancer Immunology Immunotherapy. As a background, I would like to say that immune checkpoint inhibitors revolutionized anti-cancer therapy. As you can see in this picture, two gentlemen who just recently earned the Nobel Prize for their discovery of these drugs. So how these drugs work? Here we can see a tumor cells and the T cells, they both expressing PD-1 and PD-L1. If these two molecules bind together, that causes an inactivation of the T cells, so the tumor will escape, will survive. But if you block it with an agent, anti-PD-1 and anti-PD-L1, that causes an activation of the T cell, so the T cell will more likely to kill the cancer cells. This sounds really promising, but what we can see in the reality is that only 30% of the patients will respond to this therapy. So that leads us to find biomarkers that could help us to increase this objective response rate. So we choose the soluble version of the so-called PD-1, PD-L1, the soluble PD-1 and soluble PD-L1. The clinical question is that these biomarkers have a clear, well-defined prognostic value in human malignancies treated with immune checkpoint inhibitors, and we constructed a PICO framework where we have a population of all kinds of cancers who received this therapy, and we compared the high and the low biomarkers, and we have overall outcomes, overall survival and progression-free survival. We did the selection, and we ended up with 16 articles. Here, my primary outcome, overall survival for soluble PD-L1. Here you can see a forest plot where we made the subgrouping based on the type of cancers. And what you can see here that the heterogeneity is quite high, which I will explain you later. And what are the numbers tell us? We calculated hazard ratio. The hazard ratio is higher than 1. That means that high biomarker level is a risk factor, meaning that these patients have worse survival rate, like in non-small cell lung cancer subgroup. If the hazard ratio is less than 1, meaning that these patients who have high biomarker level have, it's a protective factor, meaning that these patients have a better survival rate, like in esophageal squamous cell carcinoma. Here, the overall hazard ratio is 1.67, meaning that these patients who have high biomarker level 67% more likely to have worse survival rates. Here, my secondary outcome, progression-free survival, we made the same kind of subgrouping with the same heterogeneity problem, and here we ended up 1.20, which is not significant result, but we ended up more articles on the protective side, which also decreased this number. However, in non-small cell lung cancer, it's still a significant risk factor. Here's also a secondary outcome, which you can see in this table. We investigated the changes of soluble PD-L1 levels during several cycles of immune checkpoint inhibitor, and what's really interesting here is that only anti-PD-L1 caused a really strong elevation of the soluble PD-L1 levels, and anti-PD-1 and no caused this elevation. So what are the strengths? That this is the first article in this I'm sorry. So this is the first article in this topic, and we have seen a significant number of articles. However, the heterogeneity, which regard the cancer type, because we compared different kind of cancers, and the tumor stages were quite different, and the cohort sizes are also different. So this caused the heterogeneity. We also compared retrospective and prospective articles. The cutoff values where they draw the line between the high and the low biomarker levels were also different. and they used a different ELISA kit for the measurement of this biomarker. However, the conclusion is that soluble PD-L1 could be a useful pretreatment prognostic biomarker. However, the prognostic value of soluble PD-L1 seems to be different around various tumors, so therefore we should interpret this in a tumor-specific context. And this might indicate that soluble PD-L1 might have a cancer-specific prognostic value. The implication for practice is to use these biomarkers, and for the research is that these biomarkers need to be investigated in a tumor-specific context, and these on-treatment flare-ups that I just showed you that needs to be further evaluated, because we still don't know what's the biological and clinical relevance of this. My second article's title, High Pretreatment Soluble PD-L1 is associated with muscle invasion and shorter survival in upper tract urothelial carcinoma. This is also a published article to Biomedicines. And as a background, I would like to say that upper tract urothelial carcinoma is a rare disease. It only takes 5 to 10% of all urothelial cancers. And I would like to say that the main question behind this article have two different separated sides. One is that preoperative biopsy taken with flexible ureteroscopy has only a limited value determining the exact stage of the tumor, so that also lead to over and under diagnosis as well. So this is rather a prognostic type of question. And the second, that in much metastatic cases, when we have to give some kind of systemic agent, chemotherapy or immunotherapy, is rather a therapy predictive question. So this is a cohort. We have 65 patients, which sounds small, but this is a rare disease. We have surgery, chemotherapy, and immune checkpoint inhibitor group, and we did the analysis with sandwich ELISA, the soluble PD-L1 analysis. Here in this result, here in the surgery cohort, you can see the association of preoperative serum PD-L1 levels. And what you can see here, that the preoperative higher soluble PD-L1 is associated with higher pathological grade, the presence of muscle invasion, and the presence of metastasis. Here in this second result, you can see that we compare the pre-treatment and the off-treatment or on-treatment levels of soluble PD-L1, which would be really similar to the meta-analysis. And what you can see that in the surgery cohort, there is a mild but significant elevation of the soluble PD-L1. In the chemotherapy, there is absolutely no elevation. And in the immune checkpoint inhibitor group, where we also included anti-PD-L1, which I showed you on the meta-analysis, there's a huge 25-fold increase of this biomarker level. We did the survival analysis, and in the surgery and in the chemotherapy cohort, you can see that the pre-treatment higher soluble PD-L1 level tended to have, those patients tended to have worse survival rates. The summary that one of the strengths of this article is the cohort size, which it's a small number, but this is a rare disease. The prospective design of this study, we have different treatment settings, and this is the first article in this topic. And however, we have some limitation that we did not have a correlation analysis of the tissue PD-L1 and the soluble PD-L1 level, which could be really useful. And the cohort sizes in the immune checkpoint inhibitor group did not allow us to make a survival analysis. Therefore, we didn't have an answer for the therapy predictive question. The conclusion is that significantly increased soluble PD-L1 levels were associated with higher pathological stage and shorter survival. Therefore, soluble PD-L1 could be a useful preoperative prognostic biomarker. The implication for practice is to use these biomarkers. And again, the implication for research is these on-treatment flare-ups needs to be further evaluated. And I just really want to give a short words about my third ongoing, this is the real ongoing project, where I will assess different laboratory parameters like neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, CRP, and LDH in urothelial cancers treated with immune checkpoint inhibitors. And we want to highlight that the metastatic bladder cancer's 5-year survival rate is only 5%, and this time we have to give some systemic agent that can be platinum-based chemotherapy and immune checkpoint inhibitors. Is still a question, what should we give? And we want to highlight that these widely accessible laboratory parameters have a prognostic value, and we made a similar PICO what I showed you in the first meta-analysis, and we are in the phase of data extraction. This is just a quick view of my 3 projects, and some additional activities, and I would like to thank you your kind attention.
Congratulations for this very nice presentation. I have a question for your first paper. You wrote we found significantly inferior overall survival in immune checkpoint inhibitor treated cancer patients with elevated pre-treatment SPD-L1 levels, but this association seems to be tumor type dependent. My question is what kind of tumor it's better, and for what kind of tumor it's not so good, and it has an option in treatment. Can you tell in this kind of tumor I do it, in this kind of tumor I don't do it?
Yes, what we can see in the tissue level, because right now we use tissue PD-L1 for the prediction of we should give immune checkpoint inhibitors or not. The tissue level. And this article is about the soluble level. And this tissue level is really interesting because, for example, in urothelial cancers, in non-small cell lung cancer, we use it for therapy prediction. However, in renal cell carcinoma, we don't use it. It doesn't really matter if it's high or low. We just give immune checkpoint inhibitor. It won't have anything in any differences in survival. So this is really interesting about soluble PD-L1 because in non-small cell lung cancer, what we had a really huge amount of articles. We have a significant number of articles. We can see that this is quite. It shows a quite trend that the higher biomarker level, those patients have worse survival rate. I know this is just one article and we cannot conclude anything on that, but this is really interesting that esophageal squamous cell carcinoma is really on the protective side. Here with progression-free survival, in this article, this renal cell carcinoma, they didn't show the overall survival, just only progression-free survival. However, it's still really significant on the protective side. So we don't know why is that happening. In melanoma, you can see also insignificant result, why in non-small cell lung cancer it's really obviously. So we still have to figure out why is that happening, but we also don't know what's the tissue level, why we saw this in the tissue level and why we see this in the small soluble level as well.
For the first topic, I have two questions. How did you find the optimal length of the treatment period, and were there any exclusion criteria for the patients?
No, there were no exclusion criteria of the patients. The inclusion criteria was those patients who receive immune checkpoint inhibitor therapy. That can be even mixed, because here you can see a mixed subgroup. So they also included anti-PD-1 and anti-PD-L1 levels, and these also mixed in regards of cancer. They also included in the same article several type of cancers. So there were no exclusion criteria. We were happy that we found this amount of articles, to be honest. And the length of the treatment, there were also no exclusion. These are really different. They're different in non-small cell lung cancer, different in renal cell carcinoma. Also, some of the articles are in metastatic cases. Also, some of the articles show the adjuvant immunotherapy. So it's quite different, and this is what also shows the high heterogeneity of these articles. So,
okay, thank you.
We did not exclude any articles which was regarded with this topic.
Thank you for your presentation. I'm wondering why those lab parameters have you chosen for the third topic? So they are non-specific ones. I understand that it's easily measurable for everywhere and everyone, but why these ones?
Because we choose inflammatory laboratory parameters. Because there's a concept behind that immune checkpoint inhibitor causes an inflammation. And what we also know from the literature is that immune checkpoint inhibitors are working better if there is an inflammation. And these laboratory parameters are expressing or they show inflammation, and that is why we choose this.
Right.
So and these most of the articles showed the neutrophil to lymphocyte ratio. Platelet to lymphocyte ratio is only just one article. We also wanted to include more like monocyte to lymphocyte ratio and other these ratios. And yeah, CRP is also an inflammatory parameter, a well-known inflammatory parameter. So yes, that's why we showed this.
Yes. There are more inflammatory parameters that are
Yes,
listed here. So you went through the whole list and you
Shows the most
find
the frequent
that these are the frequent
most
ones which were
frequent ones,
reported.
Yes.
Okay. And
These are really famous. There are a lot of articles just with the surgery, neutrophil to lymphocyte, with surgery, with this kind of cancer, with chemotherapy, and so on. These are really famous parameters.
According to your first project, you stated as an implication for practice that we should consider the level of this biomarker during the treatment. But for me, it's so unspecific sentence that could you please tell me a real world example for this with a patient situation? So as a pediatrician, how I can imagine it works in real life, that your results, so how you can really implement this result in the everyday practice.
Well, at this level in the science, there are a lot of biomarkers. They are currently investigating huge amount of biomarkers, and I think in the future we should definitely, or we will be able to design a model where we able to put a lot of different biomarkers, a lot of different other confounding factors, and the based on this therapy predictive model will tell us that okay, you should give this kind of therapy to this patient or you shouldn't. So that is a leap forward to precision medicine. So therefore I am saying that we are not only investigating this biomarker, we clearly see that there are some differences with the survival, and therefore we should put this in a future model. However, there's a huge amount of things that we should investigate in the future, because we still don't know what causes these differences around the cancers.
Can you go to the implementation slide of you? So yes.
No.
This one, yeah. So that the pre-treatment, for therapy optimization. So based on what you already told us, is that that at this level there is no change in the everyday practice based on your results.
No. Because these are just a meta-analysis of half retrospective and half prospective trials. However, there is still one prospective randomized controlled trial which will be finished in metastatic renal cell carcinoma, and which will be finished in 2024, where they give nivolumab to high and low biomarker patients, and they follow them prospectively. And maybe that one will answer the question, but there's only just in metastatic renal cell carcinoma, so they should do this in every kind of cancer with every kind of situation. So it's still a lot.
And then a short comment, which does not reduce the value of your work, but I have missed the references on the introductory part. I recognize the picture of the Nobel Prize guys, but I've missed the correct reference.
Sorry. Yes.
Thank you. Continuing on this line, I have one suggestion for you. If you go out into a large congress and not in a place like amongst friends like here, don't use the word significant to highlight that you had many papers. You keep saying that you had significant number of papers. In science, you kind of have to reserve significance for specifically what it means. Can you go back, please, to the box plots of your second project? I didn't really understand what the p-values mean here. Can you please elaborate? What is the test here, and what are you comparing to what?
These are non-parametric Mann-Whitney or U or Wilcoxon tests, where we compare where we have different groups, those patients who have G1 and G2 and G3, and we compared the levels.
But you compared everything to everything, or you just compared these pairs where we have p-values for?
No, we compared everything to everything.
Okay. Okay, thank you.
I've been involved with biomarker research now for almost 30 years, and there is one lesson I learned. Whenever there is a signal that a biomarker is associated with better or worse survival, I can't really recall any result, at least in my field, that it has any clinical implication, right? So although we know that high lactate levels correspond to higher mortality, but I mean, none of us would withdraw treatment just because one biomarker level is out of its normal range. Your vision on the role of biomarkers at the bedside?
Well, you're right, but for example, if we see this tissue PD-L1, they use it for several cancers, so because it's widely accessible. For example, tumor mutation burden, there's also have a predictive role, and microsatellite instability within the tumor, there's also have a prediction role for immune checkpoint inhibitors, but this is so expensive to measure that. But tissue PD-L1 level is cheap and also a predictive role, so they included that, so there's still in the guidelines for several other cancers to use it as a level, but we have to design randomized controlled trials based on the biomarkers. And this is not really went through the everyday practice to design these kind of trials. Because mostly pharmaceutical companies don't really interested in to restrict their therapy to a certain amount of patients who have these biomarkers. So they really sponsoring those kind of trials which tells to give this drug or don't give that drug, or to give my new drug to this patient or not. And they're not designing biomarkers, which will biomarkers based control randomized control trials, which will tell them to don't give that.
You're saying, please correct me if I'm wrong. So you're saying that you measure this biomarker, and if it is high and associated with worse outcome, then you will not include these patients in a trial which tests the efficacy of a certain drug, or else. So you want to identify patients who have high risk for survival, so let's treat them with an expensive drug. Is that what you mean?
Well, if I will have the possibility to design a trial based on this kind of biomarker, I would definitely make, first of all, two groups, high biomarker and low biomarker level group. And within the high biomarker, I will give immune checkpoint inhibitor and chemotherapy or previous drug. And in the low, I also make a randomization to give this drug or not give it.
Excellent.
And I will say that in the high group or in the low, there's a better survival rate compared to those patients who I don't give that drug. And in the lower, in the other one, I would see no difference. Then I would say that, okay, this biomarker level have a clear, defined therapy predictive role.